Thank you for great introduction. So I'm Katsusuke Ozawa from Tokyo, Japan. And I'm working at National Center for Child Health and Development in Tokyo. So thank you for giving a good opportunity to have a presentation at ISUOG 2023. So I will start my presentation. And this is a disclosure of conflict of interest. The presentation was founded by Canon Medical system. So some fetal therapies are invasive to pregnant women. Invasive therapy causes pregnancy complications such as preterm delivery. In fetal therapy, we should compare the effect on the fetus and the invasiveness to pregnant women. I classified fetal therapies into 4 categories according to the invasiveness to pregnant women. Open surgery is most invasive fetal therapy. Second, fetoscopic surgery, so like TTTS and fetal for severe CDH. And ultrasound guided interventions are less invasive. For example, thoracoamniotic shunting, radiofrequency ablation, and fetal aortic valvuloplasty. So first, I talking about thoracoamniotic shunting for fetal hydrothorax. Fetal hydrothorax is classified into 2 categories according to cause. When we cannot identify an underlying disease causing hydrothorax in the fetus, primary fetal hydrothorax is considered. The survival rate of primary fetal hydrothorax with hydropus is 50 to 60%. So if we don't see skin edema or ascites in the fetus, survival rate is much higher. So when we find a disease causing hydrothorax in the fetus, secondary fetal hydrothorax is considered. For example, bronchopulmonary sequestration, cardiac disease like Listerine anomaly, and chromosomal abnormalities. So massive pleural effusion causes fetal lung hypoplasia and respiratory failure in neonates. In some cases of fetal hydrothorax, a decrease in circulatory volume can lead to fetal death. So this photo is skin edema, the fetal head, and this picture shows bilateral pleural effusion and small lung. And also we can see skin edema in thorax. CCO, combined cardiac output, can be measured to assess fetal circulation. For combined cardiac output, we measure the diameter of outflow tract and velocity time integral of the outflow as a portion of aortic valve or pulmonary valve, and then combined left and right cardiac output. So Doppler assessment is very important to evaluate fetal condition. This is a case of fetal hydrothorax, and we performed fetal thoracentesis at 29 weeks of gestation. This is the before, and this is after thoracoamniocentesis. So after fetal thoracoamniocentesis, the velocity of umbilical venous flow decreases, and the diastolic velocity in ductus venosus flow and umbilical artery flow also decreased. This is a case of left-sided pleural effusion. We can see small lung here. And with the heart located on the right side, if we perform careful ultrasound examination, we can identify a high echogenic mass in the fetal thorax. So this movie, so here, which is indicative of a bronchopulmonary sequestration. So need careful ultrasound. In Japan and Korea, also, double basket catheter is used for fetal thoracoamniotic shunting. The catheter is made in Japan. I show you how to put this catheter into fetal thorax. Moving here. Okay. Sorry for Japanese. First, I put juicer into fetal thorax through the maternal abdomen with ultrasound guide, and then just put the introducer and put the pusher into the introducer, and after making sure the right location of the catheter, I release catheter from the pusher. It's just making the right position, and then remove the pusher and the introducer together. So this is a push the fetal body and make sure the right position of the catheter. So this is an outcome of children after fetal thoracoamniotic shunting. The survival rate was 63% in fetuses with hydrocephalus. And when the fetus didn't have hydropic status, the survival rate was much higher. The Canadian study also showed similar survival rate, 65%, in regarding to developmental outcome. The interesting study showed 84% of the children had normal neurodevelopmental outcome at 18 months after birth. However, fetal hydrothorax that we thought primarily first time and couldn't identify any underlying disease before birth may include various genetic diseases. This is the data from my institute. In 25 fetuses who underwent fetal thoracoamniotic shunting, we excluded 4 chromosome abnormalities, and we performed whole exome sequencing in 19 fetuses and found genetic abnormalities in almost half of them, including Noonan syndrome and mucopolysaccharidosis, 2 cases, 7, the type 7, 2 cases, and Kabuki syndrome. So we published a paper regarding mucopolysaccharidosis 7. We reviewed fetal hydrothorax associated with mucopolysaccharidosis 7, including our 2 cases. The clinical features were early diagnosis, less than 26, sorry for small figure, but so less than 26 gestational weeks, and 93% of them were diagnosed before 26 weeks of gestation. And also the bilateral effusion and the survival rate is very low, 20%. And almost all cases had skin edema. So that's the clinical features. So next topic is twin reverse artery perfusion. sequence. TRAP sequence occurs in 1% of monochorionic pregnancies. Arterial anastomosis reported survival rate. Academic things is perfumed by through arterial anastomosis retrogradely, and hyperdynamic circulation causes high output cardiac failure in the pump train. The reported survival rate was 35 to 55% in expectant management. Left side ultrasound photo shows an actual view of a aqueducting. We can see retrograde flow in umbilical arteries. This is a right side ultrasound photo shows sagittal view of the aqueducting. Also, we can see the retrograde flow in umbilical artery and descending aorta. We can see the heart of pump train in this case. We sometimes observe cardiomegaly and thoracospidal regurgitation in TRAP sequence, but in this case, we didn't see them. This is a short axis view of the right ventricle. In this case, I obtained a very nice view using Aprio I600 ultrasound machine. Yeah, we have to assess cardiac function of the pump train in this TRAP sequence. Of the left side photo shows myocardial performance index, T index, is usually not high value because afterload of the heart is not very high, which is different with recipient of TTTS, right? But combined cardiac output, the right photo shows, often increases in the TRAP sequence because pump train supplies additional blood flow to the cardiac train. RFA, radiofrequency ablation, is performed with ultrasound guide. In my institute, we use 17-gauge Boston scientific needle like umbrella, like this picture. And the target, we put it through the maternal abdomen into the cardiac train. The target is a portion of the umbilical artery that just runs into the cardiac body. We open the umbrella step by step, 5 millimeter, 1 centimeter, 15 millimeter, and up to 2 centimeter. Yeah, just we put the needle into the cardiac mass and ablation. And in Japan, RFA is performed between 15 to 27 weeks of gestation. We measure abdominal circumference in a cardiac train and pump train, and then assess the ratio. The abdominal circumference AC of a cardiac train was divided by the AC of pump train. We assess the ratio, and then the indication of RFA is more than 1.0 of the ratio, or any sign of cardiac overload. So this is the outcome of children after RFA. Left table, this shows survival outcome of pump train. Survival rate was 85% in my institute. That was similar with other reports. The average of gestational age of delivery was 37 weeks gestation, and also that's I think that's great. So, and the right table shows developmental outcome of the children after RFA. So median age of assessment was 2 years and 5 months. we can see favorite developmental outcome in all fields, motor and language, manipulation, and social skills. So final topics is fetal aortic valvuloplasty for critical aortic valve stenosis. So this is a case of critical aortic valve stenosis. We can see large left ventricle. The contraction of the left ventricle was not well. In the right side ultrasound movie, we can see left to right, that's blue color flow, directed flow of the foramen valve. Aortic valve is not opening well here. That's left ventricle and aortic valve. The pressure gradient in this case here as the aortic valve flow less than 20. So it's a little bit low. So if the pressure gradient will be more than 20, like this photo, the fetus has a greater chance to get biventricular outcome after fetal cardiac intervention. So we can see monophasic mitral valve inflow here and mitral regurgitation in this case. Monophasic inflow pattern suggests diastolic dysfunction in the left ventricle. We can also see biventricular flow pattern in the pulmonary vein in this case. That's forward and flow and back flow. This movie shows retrograde flow in the transverse aortic arch. Here we can see the red flow that's retrograde in the aortic transverse arch. The Doppler pattern is here. So that's criteria of fetal aortic valvuloplasty. So we perform fetal aortic valvuloplasty at 29 weeks of gestation. In this case, I put the needle from here, the left ventricle. Yeah, we put the 18 gauge needle through the maternal abdomen in the left fetal left ventricle. Here, that's needle tips. And put the needle in front of aortic valve. The guide wire was inserted into the needle and insert 3 millimeter balloon through the guide wire here and inflate. So we inflate 2 times. Yeah, and remove the needle. Yeah. So Boston Children's Hospital Group established the criteria for fetal aortic valvuloplasty to obtain biventricular outcome. If the fetus has a large left ventricle, no mitral stenosis, and more than 20 of the systolic gradient, we can expect better biventricular outcome. So this is the outcome reported from Boston Children's Hospital in 2020. In all cases, the left side here, 50% of biventricular outcome in FAV success cases. The technical success rate 84%. But after modifying the criteria I mentioned before, the technical success rate 94% and biventricular outcome was 66% in the success cases. That's amazing rate. So, take-home message. Ultrasound-guided interventions are less invasive, but require technical skills. Use a high-performance ultrasound machine to obtain high-quality images. Visualize the details of the fetus's structure to ensure a safe procedure. Thank you for attention.